Good afternoon, everybody. Welcome to our Centre of Excellence in Severe Asthma webinar. Welcome to those people in the room here in Newcastle, and also to those that are online, and to any new participants that are joining us for the first time today. So we do have both live participants as well as online, so I'll ask that the audience here keeps noise to a minimum where possible, because it's difficult for the online participants when people are making lots of noise like that. I'm not banning a cough, but so before, my name's Vanessa McDonald. Before I introduce the speaker for today, I'd like to wish everybody a happy Women's Day. And today we've got a webinar titled Clinical Trial Endpoints for Severe Asthma. So we've got an international guest visiting us here in Newcastle this week, and that's Rob Niven from Manchester University and the University Hospital of South Manchester. So Rob runs a very large severe asthma clinic, and he's assessed over 2,000 severe asthma patients, with around 50% of those referrals being patients on maintenance oral steroids. He's a core member of the UK National Severe Asthma Network, and he has, which has nearly 1,000 patients entered into this national database from multiple centres, and Manchester is a key contributor. So Rob's published widely on a range of different things related to severe asthma, and it's a real pleasure to have him here with us today. So I'll hand over in a moment and let Rob get on with it. But before I do, I'll just mention that after the webinar, we'll have questions from the virtual audience as well as the real audience. So for those online, if you can type your questions into the software available, we'll then read the questions out and have Rob answer those. So without anything further, I'll now hand over to Rob. Thank you.
So Vanessa, thanks for the introduction. Thanks to everybody in the audience and whoever is online. This is a first for me doing a combined webinar and lecture in auditorium, so hopefully it'll go well. As for banning noise, that's fine as long as you laugh at the appropriate places, because it'd be very depressing if you don't. The concept is of this title, which I gave to the organiser, and Steve particularly, was to offer a talk which was planned to be controversial. So a lot of what I say is challenging some of our principles and ethoses in clinical trials, or those that have come over the years, and actually some that on which guidelines are based, as we'll come to quite soon. So just to orientate you, what I'm going to talk about is outcome measures and what matters. And of course we have different interests and requirements within clinical trials, and we primarily want to end up with a treatment which matters to patients. And so we have what matters to the patients at our heart, we have what matters to us as healthcare providers and to the payers, wherever that may be. But often we're driven by pharma, and of course that can influence us, sometimes for good and sometimes as for bad, and that's where some of my controversies might come from as I go through my talk. And just to set the scene, historically in asthma, FEV1 had been the primary endpoint for years and years and years. And attached on the slide here is a reversibility test done in my institute. But this is a reversibility test not to a bronchodilator, which you might have imagined it was, a before and after bronchodilator, nor is it to a trial of oral steroids. But this is a reversibility to a trial of injected steroids, which we do from time to time in people with very severe asthma. It takes out adherence out of the measure, and sometimes you get the most remarkable responses. The baseline FEV1 was done on this lady, and at that time we also measured prednisolone and cortisol levels, and she was compliant with oral prednisolone, and she had a suppressed cortisol, so she was adherent with her treatment enough of the time to do that. When we gave her a Kenalog jab, which lasts low-dose steroid for a month, you see a dramatic response. The other thing interesting about the FEV1 is that historically the FDA, who set a lot of clinical trial protocols, would only accept FEV1 as a primary outcome measure. They wouldn't allow any other primary outcome measure. And going back years, you'll be aware of a study called the FACET study, which has massively influenced our guidelines in terms of asthma management. And for those of you who are young enough not to know this, this was a trial where LABAs were introduced on top of inhaled steroids, and what they did was from baseline, when people were on low dose inhaled steroids, they either added in a LABA or they doubled the dose of inhaled steroids to make what is called high dose inhaled steroids, or you had both. And using the FEV1 as a primary endpoint, what you see is that the two lines at the top here, the purple line where they had high dose inhaled steroids and LABA, or here the LABA with the low dose inhaled steroids, you got a much better impact than if you used high dose inhaled steroids. And as you'll be aware, our guidelines, international, I'm sure in Australia and certainly in the UK, still put LABA as the next treatment for asthma after low dose inhaled steroid. These days, we've become much more focused on exacerbations as an endpoint, primary endpoint. And if we look at the FACET study and the Greening and Woolcock study, which of course also did exactly the same, could have shown no slides, just the same, showed the same outcomes. When you start looking at exacerbations, we see different things. In this study, they did mild exacerbations as a secondary endpoint. Mild exacerbations was an increase in rescue salbutamol use or a drop in peak flow for 3 days. And what we saw then was that there was nothing between the increase in high dose or the addition of a LABA in terms of the outcome measure. But when we went to severe exacerbations, which is what we would use as a primary outcome measure today, actually what was clearly apparent was that high dose inhaled steroids was a better treatment than the addition of a LABA at this step of the guidelines. And the same data exists within the Greening and Woolcock study, but not quite as clear cut as in the FACET study. And of course, if we applied the rules that we apply today, i.e. what's the best treatment, we would be starting at high dose inhaled steroids before the addition of a LABA. The reason that we don't was because at the time this trial was done, FEV1 was a primary outcome measure of interest. We have never looked back with guidelines to question this data, but actually we should have done. Another set of exacerbation data which I'm going to challenge is a very famous study done by Ruth Green and my friend Ian Pavord in Leicester. And they did a study measuring sputum eosinophil to direct treatment. And everybody knows this slide, it's been shown 1,000 times. And what it shows is if you use sputum eosinophils, you get a massive reduction in exacerbations over the people who were just managed clinically. And look at the magnitude of this impact. It was a huge impact. I'm going to challenge this a little bit later on. We'll come back to it. But let's get rid of some things first. Peak flow. Here again from the FACET study, the sort of impact that using peak flow gave us in terms of response. But I challenge you to what the meaning of a peak flow is to a patient. And certainly in the Northwest Severe Asthma Service, peak flows as a clinical measure are put in this place. There is a sort of rationale behind that from my point of view. When dealing with the severe asthma population, and that's what I'm referring to, is it is a very subjective endpoint. And if I have a patient who is in my hospital bed or in my clinic and desperately wants to impress you, wants to get out of hospital because they don't like being there, they will go and put a massive effort into the process. And yet, if they're a bit depressed and their husband beats them and they don't want to go home, they'll get the peak flow machine and go. And I would give you two totally different results by doing that. If you have a good physiologist or a flow volume loop, you can pick this very easily. But with a peak flow, you have absolutely no chance. And it doesn't matter whether you're using an old-fashioned one or a digital one, they are completely vulnerable to patient manipulation. So they're out of the way. And then came quality of life. Liz Juniper invented the AQLQ, or developed it, and now we all use it. And then there's the ACQ and the ACT and all of these things that measure control or measure quality of life and health status, but they're all questionnaire based. And what was demonstrated in these trials is the validation of a clinically meaningful benefit, i.e. if you went up by 0.5 on the AQLQ, that was clinically meaningful to the patient. They recognised that they were better when they got to 0.5, so it meant something to them. So I was involved in a trial of bronchial thermoplasty, and at the time we thought it was a good idea not to have FEV1 as a primary outcome, because actually we already knew that FEV1 would not go up with this treatment. We had enough baseline data to show that. And we did something very challenging, is we went before the FDA and said we want to use AQLQ as a primary outcome measure. And at the time that was probably the right thought, but it wasn't for the, it was a wrong thought, but not for a reason that at that time I knew. Because this line I'm showing you is what we got from the placebo impact of bronchial thermoplasty. For those of you who don't know this work, what we basically did was, bronchial thermoplasty involves doing a bronchoscope on a patient a month apart, 3 times, applying a basket to their airway and heating it 65 degrees for 10 seconds at every point that you can access. And what we did for the sham study patients, they had their 3 bronchoscopies, they had midazolam, their bronchoscopy time was exactly the same as those treated. We applied the basket to the walls of the airways, we clicked the on button, the button beeped and flashed just like with a real life thermoplasty, but the heat wasn't applied, and that was the only difference. And we had to have a treatment team separate from an assessment team, because when you do this, you see what the damage the heat does to the airways. And it's quite impressive. So it's very obvious to those doing the procedure whether you're using the active or the placebo control. So what we got with sham bronchial thermoplasty was the greatest ever impact of any asthma treatment ever, before or since, in the management of asthma. Nothing has achieved this AQLQ benefit, active or placebo before, and the active treatment did a little bit better. We managed to dodge a bullet with this and got it published in the American Review, despite the fact that we didn't actually achieve our primary outcome measure. And we managed to fudge that, and the reviewers of the American Journal didn't actually notice until after it was published. And it was only afterwards that people started going, I didn't get their primary outcome, why was it in the Blue Journal? But it was. And this improvement in benefit was clearly not clinically significant either. So although we got very close to statistical significance, we didn't get a clinical benefit meaningful to patients. The other question here is it still valid? Do we know this questionnaire works when you have a placebo response of 1.1? Is an improvement of 0.5, or that's still validated? The answer is absolutely not. Nobody knows what happens to the usefulness of this tool when you get such a big placebo effect. Does this affect other treatment modalities? And this is a summary of the impact of placebo on AQLQ, dependent on what type of treatment you are giving the patient. So, as all of you know, you get better if you're on placebo. And our capsule or inhaler, placebo, act equivalently with a benefit of around 0.4 over baseline. If you start giving subcutaneous injections, like with Zoa or mepolizumab, your placebo impact is about 0.7. You start giving IV injections, as with mepolizumab, as with reslizumab, you get nearly a 1. You do something really, really interventional to somebody, they really think they're getting better. So this is why do patients respond like this? Why is it the more nasty thing you do to them make them feel most better when they're getting nothing? And here's my challenge. I think this now, years on, I think this is the love chemical. And we know that there is a stress chemical. The Canadians have very nicely identified a stress chemical that causes worsening of asthma under chronic stress. Why is there not anti-chemical to that? There must be. You do something, you wrap them up in a research study, and you do all of this to them. They feel loved. So some of the placebo response is not just adherence. It will be other things as well. And then what happens to reactivity? This is a very objective primary outcome measure. And in the same work that was done in bronchial thermoplasty, I just use this as an example to beat up my own work. Not that this was my work, but beat up the work I've been involved in over time. We demonstrated in the pilot study, was a really good improvement in bronchial hyperreactivity when you do it in a single centre. It was a secondary endpoint, and I'm glad we didn't have it as a primary outcome measure, but once you went to an international multi-centre study, you get the same margin of improvement, but the standard error of the test, the way it's performed and the accuracy of it, becomes much too wide, and you lose the statistical significance. And I could have shown data from lots of drugs. Bronchial thermoplasty seems to get the most attention, but studies using montelukast, anti-IgE, anti-IL-13, fancy high-dose inhaled therapies and complex regimes, including LABAs and LAMAs, failed to demonstrate a reactivity benefit over long-term clinical use in trials. Why is that? And I do so show some localish work from Anne Woolcock and Helen Reddell from quite a lot of years ago, obviously now. But the time it takes reactivity to improve, when it is going to improve, is massive. 12 to 18 months before it starts to plateau out. And that's another reason why reactivity isn't particularly favoured, especially when pharma are driving it and they want a short-term answer. And we'll come on to short-term answers and how pharma drive that in a minute. So reactivity has kind of lost its way, which is leaving us very little, because not much of this is very good. Eosinophils and airway inflammation as an endpoint. Well, it's objective. You can blind it. We want to get rid of eosinophils and airway inflammation, and studies have done it. I'll just show you a couple from the literature. This is from IgE, so omalizumab over placebo, significant reduction in eosinophils in blood in this one, and again look at the placebo impact, half that of the real one, such an objective endpoint. And then sputum, and anyone doesn't believe it yet, there's clear data that omalizumab years and years ago was anti-eosinophilic. It just has a license for use in in people with a high IgE. But does that matter to our patients? And actually, when I sit down with my patients and ask them what is it they want, what endpoint would they most want out of us treating them? And Vanessa very kindly introduced the fact that the vast majority, well not the vast majority, a huge amount of the patients I see are on oral steroids maintenance when they come to us. And the rest of them are on at least 4 doses of oral steroids a year, because we shouldn't be seeing them really unless they're on that sort of frequency of dose. And what they want is to get rid of steroids because they don't want to end up with all of these side effects. And not included there is the neuropsychiatric ones, which in a way can be the worst of all. So they don't want steroids. And that takes me back to the Ruth Green data. Oops, no, it doesn't. Sorry, it takes me to steroid reduction first. Apologies for that, especially those online, because I'm making it difficult for you to follow. But we have studies which have demonstrated reduction in oral steroids, but most of these are actually open label studies. This is an open label follow-up study that we did in the UK, and are similar ones done internationally. The Experience Registry as well, showing that you use these treatments and you can reduce steroids. If you do a steroid-sparing study in a blinded placebo-controlled trial, that's also very challenging. We've just finished one involving one of the monoclonal antibodies that might have been steroid-sparing, and we got big improvements in steroid maintenance dose in the placebo and in the actively treated group, and absolutely no difference between the two. So it is also vulnerable. So on to my challenge of the Ruth Green data. which everybody seems to miss, gets very excited by this data, and Ruth and Ian know that I challenge this as friendly as I can, because what they showed was this massive reduction in exacerbations. And the definition of an exacerbation for the study was the course of oral steroids. But yet the use of prednisolone, averaged out over the whole time of the trial, was almost exactly the same and didn't reach statistical significance. And the question is, how can that be, when the only reason to give steroids was an exacerbation? The only way you defined an exacerbation was the course of oral steroids. How come the outcome of oral steroid use was the same? And the answer to it is buried in the methodology. And here's another challenge to you setting clinical trials. So the methodology allowed you to give a course of oral steroids for 7 days if somebody had high eosinophils on their sputum at their clinical visit, and they were on maximum dose inhaled steroid. But that wasn't called an exacerbation. If they had high eosinophils and had symptoms and were in the clinical treatment arm, and they were given a course of oral steroids, that was called an exacerbation. So actually, the way they showed the difference between these two endpoints was, I think, a sort of cheating as well, in that they didn't define an oral course of oral steroids when you were on top dose inhaled steroid and you had eosinophils in your sputum as an exacerbation. And I would challenge that that really isn't relevant to my patients. So finally, payers. What are payers interested in? Well, payers want the treatment to be cheap and they want the outcomes to be cheap. So they're interested in these things. What costs a lot of money? Emergency visits to A&E, hospital admissions, and unscheduled doctor visits, which I don't know if they equate in Australia. They are very much an American definition, which means that unplanned emergency visit to a doctor, usually a primary care physician. These don't exist in severe asthma patients, because our severe asthma patients contact us if they have an exacerbation and we treat them. They don't see their primary care physician very much. But these are what payers are interested in, because these cost money and they're expensive, especially if you're admitted to hospital, and especially if you're admitted to hospital and end up on an intensive care unit. So this is maybe where some of the future is. And now what about pharma now? I demonstrated to you how pharma have influenced our guidelines, because they drove the peak flow and FEV1 at a time they were bringing in a long-acting bronchodilator. That wasn't all their work, but it was a large chunk of it was their work. What about now is we have this fantastic array of drugs that are going to be available to us. I know you've already got mepolizumab in Australia. We don't get it until April, shortly after I get back from my trip. And then potentially some or all of these coming on behind. And so what have pharma been doing with the endpoints for these studies? Not surprisingly, they've been choosing the ones that suit them. Let's start with the anti-IL-5s first. We had a much more important lesson to learn from this, which has been slow to learn and hasn't really been learned by some of the more recent studies. But when you start with one of these drugs, if you go for asthma generally, any asthma, you find no benefit. The benefit only comes when you start to get into treating the people who really have got eosinophilic asthma. And so when you start looking at that, what you demonstrate, because an anti-eosinophil drug is likely to block exacerbations, then you get a significant reduction in exacerbations. Quite interestingly, in the MIPO data, or certainly the original MIPO data, that there wasn't really a dose-response relationship. You reduced exacerbations even at the relatively low dose of 75 milligrams of MIPO. Benralizumab, which is an even more potent anti-eosinophilic agent, significantly and similarly in impact reduces exacerbations. The rather interesting nugget that has come out of this more recent clinical trials of benralizumab is that 8-week dosing is better than 4-week dosing. Not just the same as, they actually do statistically significantly better with 8-week dosing. And that's really interesting. Same dose given less often is better. That really needs answering the question to that, because it's telling us something that we don't know yet about these drugs. Anti-IL-13s, well, they do impact on eosinophilic airway inflammation, but they do it through a different mechanism. And because they also have a bronchodilator effect, the companies in the early phases of these studies have been looking at FEV1 as a primary endpoint again, because it suits their drug. We shouldn't really let that happen. We want to know what is right for our data and what we believe. But it can be worse. So I finish with the final controversy. Dupilumab looks like a great potential drug. It blocks anti-IL-4 and anti-IL-13, and there is clinical rationale why this may be the best drug available. But I have serious concerns over this drug, not because of the drug, but because of how it was brought to clinical presentation with this trial. And what they did was learn a few lessons. They went for the eosinophilic population, quite right. What they did was start them on dupilumab, and over 12 weeks, they took away both LABAs and ICS from a group of patients with severe disease. And their primary outcome measure was the time to the first exacerbation. This is the number of exacerbations. It clearly works, but how ethical was it to do this to a group of genuinely severe eosinophilic airway asthma patients, where you were taking patients on placebo, off LABAs and off ICS? And for me, the fact that nobody died in this study is a pure fluke. And this study should never have been granted ethical approval. It was only done in one country. I suspect you won't be surprised by which country it is. But it was a country that wouldn't let us use anything other than FEV1 as a primary endpoint until 7 years ago. But anyway, so we've got a bright future for lots of drugs, but it's time that we, as a clinical and research group, took ownership for what matters to patients and what primary endpoint should be in clinical trials. Because actually, eventually, they should be the same thing that matters to the patients down the line that we're going to use it on. Thank you for your attention. Now, I've gone too fast. I've left far too much time for questions.
Thanks, Rob. We'll just see if we've got any online questions. In the meantime, take a question from Peter Gibson.
Thanks, Rob. My question is, if oral steroid side effects is what matters to patients, then that would suggest the perfect trial design is to take maintenance oral steroid users and withdraw their oral steroids and see if the drug allows that to happen. You just criticised that approach as being unethical. So tell us what you think about that.
So I don't think it's unethical.
I might just repeat the question for those online in case they didn't hear that. So Peter has suggested that, or Peter's questioned Rob on his statement about the reduction of oral corticosteroids being most important to the patient, but then has criticised a trial that has reduced inhaled steroids and LABA, and asked what he thinks would be the best trial design.
Yeah, so I think there are two issues really. There's the oral corticosteroid sparing, which I would see as a very good patient-focused outcome. The reality of doing those types of studies is that they are really fraught, certainly at the moment, with the fact that you get a huge oral corticosteroid sparing effect by bringing people into a trial. So the placebo people get a big reduction. And there's been very few trials that have successfully been able to demonstrate that in a randomized controlled trial. So we see it in open label follow-up, and we see it in open label studies, but then that could just be being involved in a study that's doing that. So it's the practical issues that are problematic for oral corticosteroid sparing. I mean, the difference there is they've got the protection of inhaled corticosteroids, And if they're going to exacerbate, they still get oral steroids at the time of exacerbation. But the criticism of the dupilumab study was that they stopped all anti-inflammatory treatments in a group of patients who had inflammatory-driven asthma, and by definition of having high eosinophils were uncontrolled, and therefore at risk of potentially serious exacerbations as part of the clinical trial protocol. And the clinical trial protocol was inducing more exacerbations than those patients would have had before the study, which of course is not what those randomized clinical trials do. So I see them as the inhaled corticosteroid withdrawal and the oral corticosteroid withdrawal are different issues. There have been studies using with Xolair, particularly in pediatric populations, where they did inhaled corticosteroid reduction, but they were relatively slow reductions and over longer periods of time, where bringing people off it over 12 weeks and waiting for them to get into trouble, I still think is unethical.
Rob, you talked about quality of life as an endpoint, but didn't really focus on asthma control. So can you give us some thoughts around the use of the ACQ or the ACT in terms of an endpoint for clinical trials, and particularly the use of those two outcome measures in a severe asthma population?
Yes, I deliberately tried to dodge that bullet, so thank you for asking me that. I think the same principle is there, that they are measuring different aspects of quality of life and control, but those two things are clearly embedded close together. So although they're not perfectly correlated, there is a lot of relationship between them. And there are other questionnaires, interestingly the Niven questionnaire, which is used for hyperventilation assessment. We've demonstrated historically that really tightly correlates with ACQ beautifully, irrespective of whether the patient hyperventilates or not. So you can see I'm hedging the answer to this question, but I think the truth is it's so vulnerable to the same problem, is that if you're giving an intervention which has got a big placebo effect, you're going to lose what you understand to be the validity of the test and the outcomes. So ACQ is saying 0.5 improvement means clinically significant. But if you're getting 0.7 by placebo, do we really know that 0.5 is the right thing beyond that? And I'm not sure we do. And I think if it's a relatively benign intervention, then they're fine. But once you start injecting people, or as we did, do bronchoplasty on people, we were completely wrong to use that as a primary outcome measure. It's easy to say that now in hindsight, but we didn't know it at the time, but we were.
So if I can just have a follow on those measures. So do you think over time we've seen studies where over time the minimal clinically important difference, or the actual effect has increased depending on what type of intervention there is? And the same has been seen in COPD studies using things like the SGRQ and the CAT. And in fact now people are proposing that the clinically important difference for those measures should be greater than what it's actually historically been published as. Do you have any thoughts on that in terms of the use of the ACQ or the AQLQ?
So you say that certainly in asthma, the number of studies which have shown an AQLQ response of greater than 0.5 over placebo is incredibly low. It wasn't achieved with Xolair, it was about 0.45. Wasn't achieved with Labas, it was about 0.4. It certainly wasn't achieved with Montelukast or Lamas or anything that we currently use, and certainly hasn't been seen with any of the MABs that are currently available, and wasn't available with bronchial thermoplasty. And the only primary outcome or a study that showed an over 0.5 was one of ours where we used antifungal drugs and got a 0.8 over placebo for the improvement in AQRQ. So trying to push that higher, I can understand why people are doing it because of this placebo impact response, but actually I think it'll make it harder for drugs to achieve it.
Steve?
I'll just stand up so we don't have to repeat it. So the question from online is whether you can discuss the use of Xolair in children.
Simple answer to that question as an adult physician is no, because I don't pretend to be a paediatrician. I suppose to be straight about it, There is good data over the age of 12. There is pretty good data over the age of 6. But the 6 to 12, I would really want to leave to a paediatric specialist to say whether I thought that was right or not. And over the age of 12, the data from clinical trials is more than convincing. And I hope that was what was meant by the question.
John Brennan?
You mentioned allergen challenge. I know at some time in the past, many years it's been used as sort of a gold standard with the drugs that have efficacy in asthma. And it didn't work so well for missing that. I was just wondering what your thoughts are on that going on here, and your thoughts of its use in the past.
So John Brennan's asking about the use of allergen challenge as an endpoint in asthma clinical trials.
John, that's a really good question, and I learnt my teeth doing allergen challenges in clinical trials quite a long time ago. I think they are potentially very useful in early phase research of a drug, just to look at its effectiveness, because you get a relatively big signal in a relatively small number of patients, which I think is why they can be used as a testing ground to see if it's worth going on. Obviously, my comment about just doing methacholine challenge or histamine challenge as a primary outcome, you've got to multiply the complexity of that with a 0 on the end. For the quality of doing allergen challenge is extremely difficult to do, and it's certainly quite difficult to do safely. So yeah, I think it has a role in early phase research, but not for the endpoints at a time phase 3 type clinical trials.
Are there any other questions from online, Steve?
I have one, but
Okay, so well, perhaps you can ask the question, and then Jody, and then Peter.
So Rob, I'm just wondering, the lesson's been learned, I guess, in part that you really need to select the patient population well for the clinical trial and to assess the outcomes. What would you say about also the same on the other side of selecting the clinical endpoints based on the drug and the mechanism and all those aspects?
So there's so many things wrapped up into that. The reason why pharma would prefer to have a patient population which is broad is obvious, because they can sell a drug to more patients and make more profit. And of course, from their point of view in the real hard world, it's getting harder to make a drug profitable, especially with monoclonal antibodies, which are expensive both to develop and cost price to produce. So we kind of get where they're coming from when they want it to the broadest population. But similarly, if they get stuck with studies, I mean, mepolizumab was the one. It nearly drowned. It was really down to the work of Ian Pavord and the Leicester group, who drove forward doing the project again in the selected population. And without that commitment from Ian and the Leicester group, mepolizumab wouldn't be available today. So that's an example of where the researcher has asked the right question and driven the right process. So absolutely fundamentally important. And then the other half of the question was the endpoint. And I think that's where we have to take charge, because I don't think that we as researchers should allow endpoints now that are the wrong endpoint, that don't matter to the patient, and that the actual clinical study that's being produced is unethical. I don't think that we should be allowing those things to go on in research at this day and age. We are driven by pharma. We need them. We won't have clinical research to do unless we have a good relationship with them, but we should stop them asking the wrong question and doing the wrong trial.
Jody.
Thanks, Rob. It was more just asking for your comment. I noticed on your last slide, and I couldn't resist asking it, so I waited to the end. But on your last slide, you mentioned that the future's bright for those with eosinophilic asthma. What about everyone else?
So Jody's reminding Rob of his last slide, saying that the future is bright for eosinophilic asthma. But what about the other 30% that are not, or 50% that are non-eosinophilic?
Well, Jodie, I saw the data from Peter's study on azithromycin recently, and I think that the data from that is very positive and strong for that group of patients. But actually, we've been clinically using it. I mean, that's a drug that's available. So, I mean, the study helps us do that. But it is a heterogeneous, morphed group. And we're currently involved in a stratified medicine approach where the patients who are being recruited get their inhaled steroid dose or their oral steroid dose modified in a rational way, not in a stop it after 4 weeks, based on 3 outcome measures of sputum, blood, eosinophils and periostin, and modified. One of the things that's happening there is that we're taking people who appear to be non-eosinophilic and gradually over months reducing their treatment. And you will not be surprised to hear that quite a lot of those become eosinophilic. Not all of them. And the other problem is that buried into this population is lots of people who probably have a different disease where it's driven by mucus or recurring infection. And then there are differential diagnoses we still don't know. We've just opened a registry in the UK for tract emulation, both the dynamic airway collapse and the relapsing polychondritis form. And you might think this would be obvious. And I can tell you we have a network approach to assessing our patients for bronchial thermoplasty. And twice in a month, we got to the point where we were doing the first procedure on a patient, camera going down, when we realised we had the wrong diagnosis. These people had reactivity that was convincing. They had airway variability that was convincing. And the things that make us want to do thermoplasty, and yet when we went down, what we saw was huge dynamic airway collapse. And those people are now on CPAP. They've not had trachea, they've not had thermoplasty. So I think that buried into that population is a huge heterogeneous group who have different disease that needs to be picked out bit by bit. It'll take us years to do that.
Peter?
I've got 2 questions, Rob. Could you say something about composite endpoints? Do you think they get over some of the problems you identified? And I'll ask the second one.
So the question is around composite endpoints, and do they get around some of the problems that Rob's identified?
Apologies for Vanessa, because I keep wanting to answer the question before she has a chance to repeat it, so my apologies. Yeah, and I think, again, the composite endpoint, as long as it's a rational composite endpoint, it is perfectly legitimate. But there is a danger that it can be created for the purpose of getting a positive answer. So it's got to be rational, it's got to be patient-orientated and relevant to our clinical population at the end of the process. So again, a long time ago I was involved in an allergen challenge study where we had a composite endpoint of either an improvement in reactivity or an improvement in FEV1 over a certain number. It was absolute nonsense. We got a primary outcome measure by doing it, but it was cheating. You know, I've criticised gentle cheating in the process already. So it's got to be rational.
And my second question was, what if we sort of turn this all on its head and actually let patient behaviour become the outcome? So if the treatment works, then the person is prepared to fork out the cash, to go to the pharmacist, and to take the treatment. So we know in Australia that people with asthma only get about 1 in 3 of their buffers dispensed. So could we just forget about all this stuff and just look at what people do when they get their drugs or not as the outcome?
So that was a long question, which I'll try and summarise. So Peter's asking, should we use patient behaviour as the outcome? For example, treatments for severe asthma particularly are very cost intensive, and they also require a lot from the patient in terms of taking the treatment, being adherent, and with some of the newer therapies coming to clinic for injection. So should we consider patient use of medication as part of the outcome? Have I said that correctly? As the outcome, and the only outcome.
So I've got a long answer to that question, I'm afraid. But I'm going to start with conflict of interest statement, I was on the British Thoracic Society steering committee for the most recent round of the British Thoracic Society. And the reason I agreed to do it was, although I was helping rewrite the severe asthma section, which didn't take very long because there wasn't really very much change in 2 years, I was driving very hard for us to change the guidance on step 1. And the rationale behind getting rid of step 1 was because, as you see in Australia, if you have a symptom-based disease that you can take a blue inhaler from, and within 5 minutes that symptom goes away, you're going to want that treatment because instinctively that's what you want. But that's short-termism. What we know, you've demonstrated beautifully, most recently I think with the thunderstorm data in Australia, but there's lots of the data that if you take lots of short-acting bronchodilator, you actually make the disease worse over a relatively short period of time. So, and then there is the psychological data. And this applies not just to respiratory disease, but any disease, whether it be cardiac or rheumatological or psychiatric. When you diagnose somebody, you have 6 to 8 weeks in which to set a patient's behaviour pattern to their disease. And once you've passed that 6 to 8 weeks phase, changing their approach to their attitude to their disease is really difficult. Psychologists from lots of fields will tell you that data. And what happened historically, and certainly happened in the UK, and I suspect happens here, is you rock up with a symptom suggestive of asthma, and the primary care doctor says, well, let's give you this blue inhaler and we'll see if it makes a difference. Not only then will you feel a bit better, but we'll also have the diagnosis. By the time they're coming back for their second visit, and you go, we might be better to put you on a preventer inhaler, it's too late. They've already got their fixed approach. And the Scandinavians, and we talk about this quite a lot, the Scandinavians solved this data by 15, 20 years ago, was it? They started the work in the 1980s. They started the work on trying to change the ethos of treatment to inhale steroids first and SABAs second. And they have achieved it by whatever endpoint you want to measure. Inhaled steroid pickup makes ours look, yours and ours, because we're about to say, look absolutely laughable. They've stopped severe asthma existing. They've stopped asthma deaths. 5 million people in Finland, they're averaging between 0 and 3 deaths a year. We've got 50 million, average 1,000 a year. Don't know what you have in Australia, but you could probably put that data alongside it. The outcome measure that really matters, is stopping people dying. And it can be achieved as long as you have the right approach of starting inhaled steroids early. I personally would like to see patients treated with inhaled steroids before SABA are ever given. And if they're not sick enough to do it that way around, then I think that would fix people's view. Taking inhaled steroids for 2 weeks, I've got no symptoms. The patient goes, I can make this disease disappear if I do this properly. And then you get the right attitude, the right approach to treatment. And Scandinavians have done it for 15 years, so you know the rest of us, unfortunately, I think are lagging behind.
We keep them before the...
Good. I've noticed you're way ahead of us. On everything except speedy trains. We're not trusting.
Are there any final questions or comments from the audience or online?
There's one question here online, and I'm sorry, I don't 100% follow it. You're saying that Kenalog intramuscular monthly is a successful mode of treatment. Wondering if patients also stay on inhaled steroids at the time, and if you could make any mention of what age it can be used.
Yes. So we would not want to leave people on Kenalog as a long-term treatment. They definitely get worse side effects than oral steroids do, with the exception of actually they don't gain weight, interestingly, like oral steroid maintenance patients do. So we would use it really as an observation as to, in clinical practice only, so not as a research tool, but in clinical practice as a demonstration of, can we make this person better? So our approach there is somebody with very severe disease, if we really are aggressive, can we make them better, or is this a patient with proper fixed airways disease? And you know, I showed you the spirometry deliberately in the old-fashioned spirometric way, because that patient would have been labelled fixed airways disease in any other setting. And yet, by being totally aggressive up front, we demonstrated that it was all asthma, it was all reversible. Somebody else had applied a label of COPD, we never have got that treatment. But that patient is not on, only had 2 doses of Kenlog, and we never went back to it again. And I certainly would only do it in adults. Historically, it's been used. It was used as a, still used occasionally to treat seasonal hay fever. It's seasonal time of year. I don't think it is in Australia. It still is in Europe in certain places, but I'm not advocating that as a standard treatment.
Okay, well with that I might draw this seminar to a close. Thank you for your interest, participation, questions and interaction, and thank you Rob for a great discussion and thought-provoking presentation. Thank you.